First off, a huge shout out to the team here at the Convention Center, Sebastian and Mike and the folks who helped put us all our audio and panel together last minute for this. So thank you so much for making this happen for us. It's a pleasure to be here with folks today. Great, thanks. Okay, now we can hear everybody, perfect. So my name's Kim Kreis, and it is a pleasure to be here with this fantastic panel today to talk about a topic, hello Dave, that's really near and dear to our heart, and that is the topic of concurrent disorders. So before I give a bit of an intro about the topic, I'll tell you who I am. I'm the Vice President of Innovation, Senior Scientist, Canadian Centre on Substance Use and Addiction, Professor in Psychiatry at the University of Ottawa, and also a Director of Evaluation at the Ottawa Hospital, where I work with people who have substance use and mental health problems. So I'm really delighted to be here with everyone today. So what we've got planned for you today is panel discussion where we're really focusing on the identification and treatment of concurrent disorders in inpatient treatment settings and looking at some interesting topics that span the gamut from how do we measure what's in our settings so that we can actually lead to more personalized treatment, what are some of the ways that we can evolve our services that we offer so that we can better meet the needs of people who live with concurrent mental health, substance use health, and physical health disorders. And then we're going to wrap it up with talking about some of the novel approaches. And you heard some of that from James this morning, and we're going to pick it up with Patrick later today, where we're going to, at the end of the panel, where we're going to talk about patient and provider perspectives on some of these novel treatments like RTMS and psychedelics and others as well. So for those of you who I'm sure you're all very well aware, there's high comorbidities of people, not just in terms of their mental health and substance use problems, but also in terms of physical health problems. Unfortunately, many of our services and programs actually can't accommodate these levels of complexities, despite the fact that I know each and every one of you in the room who are service providers or researchers are doing your utmost with limited, likely, resourcing and limited teams and networks to be able to bridge the gap and bridge this divide between substance use and mental health. So I hope today gives you some thought about strategies, about information that you could use to maybe propel some of the evolution in your services when you're advocating for how we're going to work to meet the needs of the people we're desperately trying to serve, and then how you can use evaluation to really guide setting up your interventions, looking at the impact of your interventions, which often will help you sustain these interventions. So I don't want to take up too much time from our fabulous presenters who are here with us today, and I am going to start by introducing James, as you are off first, and I know you just had your bio read, but in case people missed it, I am going to remind them as to who you are and where you're from. So we're lucky to have James here with us, who, as you folks know, holds the Peter Boris Chair in Addiction Research and a Canada Research Chair in Translational Addiction Research at Mac University and St. Joseph Healthcare Hamilton, where he both directs the Peter Boris Center for Addictions Research and the DeGroote Center for Medicinal Cannabis Research. James is a professor, he is a clinical psychologist, and he does much work fostering on integration, not just in terms of conditions and perspectives, but also in the technologies and various approaches he uses to answer some of our most ubiquitous questions. Over to you, James.
Thank you, Kim. I really appreciate it, and it's great to be with you again. This time I'm going to be talking about more of our applied research and how we're trying to use a strategy called measurement-based care to improve the management of concurrent disorders in our substance use treatment programs. I do want to give some acknowledgments. So some of this work is informed by the Homewood Research Institute Working Group on Progress and Outcomes Monitoring. There's a workshop this afternoon focusing on the PALM project, and I encourage people who are interested in learning more about this to attend that. I also, that's okay. I also need to credit Health Canada, which has provided a SUOP grant to support the measurement-based care program that we're implementing at St. Joe's. And these are my disclosures just to make sure that I'm transparent again. So basically what I want to do today is give some information about just the scope of comorbidities, psychiatric comorbidities in substance use disorders, and then talk about the measurement-based care triple aim network framework that we use, in which we really try to make data work as hard as it can for our patients and our programs. I want to talk about how we're using that MBC system to inform comorbidities, and ultimately include some hopefully thought-provoking slides about how to think critically about measurement-based care. So what do we know about substance use disorders and psychiatric comorbidities? So first, we know that there are very high comorbidities. In particular, for what we would have called before Axis 1 conditions, the highest prevalence rates are for major depressive disorder, for anxiety disorders, and for PTSD. We also know that there are extremely high comorbidities with cluster B personality disorders, antisocial personality disorder, and borderline personality disorder in particular. We also know that in clinical settings, not only is this the case in epidemiological surveys, but in clinical settings, this is really the norm rather than the exception. Most patients have, in addition to a substance use disorder, at least some comorbidity, often multiple comorbidities. And this is truly endemic to both specialist care for substance use disorders, but also for psychiatric care in general. This is really the reality on the ground in terms of clinical care. And we have a lot of challenges in how we manage this. So there are blind spots that are kind of present at multiple levels of analysis. So programs tend to be organized either towards a specific indication. So they are focused on substance use disorders or mood disorders or anxiety disorders. So they inherently have blind spots about comorbidities. Clinicians don't ask about the conditions they're less familiar with or less comfortable treating. So they tend to be less oriented towards managing comorbidities. And sometimes patients may not be aware that they have co-occurring conditions and may not report them. So there really are blind spots at multiple levels within the clinical enterprise. And just to give you a sense of how substantial this is a review of meta-analyses. So a review of reviews that indicates that the likelihood of having a co-occurring depressive disorder among individuals with alcohol use disorder is about 2.5 times more likely, with the drug use disorder nearly 4 times more likely, and when it comes to an anxiety disorder, those rates are again similar. So nearly 3 times more likely for individuals with a drug use disorder to have an anxiety disorder, and twice as high for alcohol use disorder. So any which way you slice it, concurrent disorders, the comorbidity of psychiatric conditions and substance use disorders is really ubiquitous. So how do we try to take this on using measurement-based care? Well, the measurement-based care system that we use really tries to solve 3 problems. It tries to collect data and provide clinicians with more information about their patients for treatment planning and monitoring in near real time. It tries to collect that data those data in a way that is easily accessible and aggregates over time to promote program-level quality improvement. And it is intended to use those same data to conduct clinical research to better understand substance use disorders in general and clinical treatments for substance use disorders. And all of this is done using electronic data capture, using validated screening measures with extensive branching logic to minimize the number of questions that have to be asked, to maximize the amount of information that can be gleaned from patients during the admissions process, and automating that using back-end technology. So really the goal for this project is to, or this approach is to make the same data point do triple the work. The data is supposed to help the patient, help the program, help the field. This is an example of the clinician report that comes out of our measurement-based care system at St. Joe's. This gives a snapshot of substance use, demographics, mental health comorbidities, history of head injury, and is really a baseball card or a hockey card for a clinician to use in order to begin the process of treatment planning. In terms of quality improvement, the data can be aggregated so we can do formal evaluations. This was a recent quality improvement manuscript that details the process and outcomes from our young adult substance use program at St. Joe's, and was led by Jillian Halliday, I believe here in the audience, or at least certainly at the conference, and is an example of how, as we collect data patient by patient, we can then convert those data into meaningful quality improvement reports that can really move the field forward. And what I'm really going to focus on, the other piece of that evaluation that I'll highlight is this was a way for us to actually document the level of positive impact in terms of both substance use and comorbid conditions. So on the left-hand side, this shows you our changes in terms of alcohol, cannabis, and other drug substance use over the 3 months of enrollment in the program. And then on the right-hand side, it shows the reductions in anxiety and depression. So this is a way to actually demonstrate the efficacy or the effectiveness of our treatments live. And then finally, we can do research which can really be illuminating when it comes to concurrent disorders to better understand clusters of patients within our services. So what we've done in a number of studies, and this is going to be the heart of what I'll present, is use a technique called latent profile analysis to try to identify these subgroups. And what I want to emphasize is that latent profile analysis is really a patient-centered or person-centered approach for identifying unobserved, qualitatively distinct subgroups within complex heterogeneous data. And what I'm expecting is that most clinicians will hear complex heterogeneous data that sounds like my clinical setting. It sounds like outpatient psychiatry or inpatient addiction medicine. The reality is there's a lot of heterogeneity in our patients, and this is a way of trying to find common patterns. Fundamentally, we see this as being one more step towards improving personalized medicine for substance use disorders, in which we can take really heterogeneous patients and then use different assays. They could be genetics, they could be brain imaging, they could be nutrition. We're using measurement-based care, but we then use those analytics as a strategy for then identifying subgroups and developing care paths that are going to better map onto those subgroups and ultimately lead to better patient outcomes. So we really want to move from a one-size-fits-all approach, which most of our treatment programs have, even with some customization, to a which-size-fits-best approach. And so we undertook this in a number of studies at Homewood Health. And what we did was we looked at alcohol severity, illicit drug use severity, and depression, anxiety, and PTSD, the three most common comorbidities. And we used latent profile analysis to see if there were specific subclusters that were emerging out of our data. And what we found was that actually there were 4 separate clusters. I'm going to highlight what they were one by one. So we had one cluster that was high in alcohol severity, but low in all other domains. We had a second that was sort of a reciprocal that was high in illicit drug use severity, but low in all other domains. And then we had a third, I'm afraid the highlighting is not perfect, that was high in alcohol severity and then low in illicit drug use severity, but high in depression, anxiety, and PTSD. So essentially an alcohol concurrent disorders subgroup. And then we had a last one that was a reciprocal of the alcohol concurrent disorders group that was high in illicit drug use severity, but also high in depression, anxiety, and PTSD severity. So essentially 2 subclusters. This is out of over 1,100 patients. We had 2 subclusters of what we might call clinically uncomplicated substance use disorder without a lot of comorbidities, and 2 subclusters that had very high comorbidities. And what we found in further analysis of this cohort was that one of these profiles was significantly associated with a much better prognosis in terms of lower rates of leaving against medical advice, and another profile was significantly associated with higher discharge rates, which we know unfortunately are associated with negative outcomes, including overdose. And that was specific to one of our concurrent disorders profiles. So these were relevant also to clinical outcomes. We then took a second group of, again, more than 1,000 patients in the addiction medicine program. We used the same technique, latent profile analysis, to try to identify latent subclusters. And we reproduced almost identically the same 4 profiles. So now you can see these depicted slightly differently. On the far left, we have our high alcohol, low everything else. On third from the left, you can see high illicit drug severity, low everything else. And then second from the left, you have high concurrent disorders, high alcohol. And then far right is high concurrent disorders, high illicit drug use, low alcohol. So what we saw over time now in more than 2,000 patients was, again, this common presentation of specific substance use patterns, either being uncomplicated or with concurrent disorders. In this study, we went further to try to understand what this looked like. So this just depicts the prevalence of actual positivity for the diagnosis. And what I'll really highlight is that you can see that in our uncomplicated groups, there were very low prevalences of depression, anxiety, and PTSD. And in contrast, in the high concurrency subcluster, we did see uniformly high levels of diagnosable depression, anxiety, and PTSD. We also found that when we looked at cravings, there were significant differences between the groups. The concurrent disorders groups had significantly higher cravings than the low comorbidity groups. That was basically a gradient or a dose response from the least complicated to the most complicated. So high drug use severity and high depression, anxiety, and PTSD was associated with substantially higher cravings, suggesting that concurrent disorders patients really need more craving management strategies. And we also looked at impulsivity, multidimensionally, looking at self-regulatory control across these domains. And what we found, there's a lot going on here all at once, but consistently, especially for, let me see if I can use my pointer, especially for emotional regulation, we saw, again, significantly higher emotional regulation needs in our concurrent disorder subpopulation. So what we see is, A, there are unobserved clusters of patients within these large heterogeneous programs. They look different clinically. Their phenomenology is associated with both good and bad clinical outcomes, and these clusters are differentiatable in terms of their cravings and their self-regulatory capacity, suggesting there's a real need for different kinds of treatment, whether it be qualitatively different or simply quantitatively more is less clear. But what's been really exciting about this work is that as a result of these studies, Homewood has now restructured its treatment program to have both a standalone substance use disorder program, but also a concurrent disorder stream that from the start extends programming for longer and is able to focus on some of these features that we've identified in, again, the more than 2,000 patients who participated in the earlier research. So this has really led to an actionable change in how care is delivered. So just to wrap up, fundamentally, we think that measurement-based care, this strategy of systematically assessing substance use and commonly co-occurring comorbidities across treatment, starting from admission and going to discharge, really offers three important assets in terms of improving concurrent disorders care. It basically improves the clinical radar. It puts things on your radar as a clinician that you might not have thought about, and it gives you a sense of the complexion of symptoms and the patterns that are present. It allows you to actually evaluate the outcomes in terms of, are you positively affecting comorbid conditions? And ultimately, it also allows you to identify, are there subgroups within your patient population that really may have different needs, and as a result, may need to have care paths that will speak to those needs. So I'm gonna wrap up here. Ultimately, I think as a kind of meta comment, my hope is that this kind of work will lead to a learning health system that allows for these data that are collected in the service of clinical care and quality improvement to ultimately be fed back into evidence that guides our subsequent care. So I'm going to wrap up here. Thank you, everybody. If you are able to give us an evaluation for our SUOP project, I would be most grateful. Thank you.
It's awesome. Thanks so much. And as just while we're getting the next slide deck on, as James said, we are in a talk, I think, Jean, right, later this afternoon. From, actually, can you put back the purple ones? From Shannon, thanks. Thank you, Sebastian. And we're going to talk more about measurement-based care at that point, and focusing, James, you talked a lot about, maybe we could talk about this at the discussion, from evaluation research lens, but a lot of work that we've done looking at measurement-based care as a clinical intervention in and of itself in a way that actually helps us improve our relationship with our patients and really help guide and course correct their treatment, and the emerging body of research in the substance use health field demonstrating how measurement-based care is an important tool in our clinical toolbox. So now I have the pleasure to introduce Shannon Remmers. As James mentioned, Homewood Health, as a result of the evaluation, the work that James did, has done some significant work evolving their programs to develop specific concurrent disorder programming, which Shannon's going to share with us today. So Shannon is the Director of Research, Quality and Outcomes at Homewood Health, Inc. She leads innovative research initiatives to optimize treatment outcomes and uses her incredible expertise to improve treatment across the continuum of care where she works and with her patients. I've known Shannon for some time, and I can say she truly is driven by advancing mental health and substance use health treatment through research and evolving evidence-based practice. Thanks, Shannon.
Okay, so I'm going to specifically talk about actually the transition and development of the program that James alluded to at the end of his presentation. I can give various other examples as we're going through of how we've used this data and infrastructure that we've been building for the last decade to really inform other changes in practice. But given the context of concurrent disorders, I'm going to focus on how it pertains to this specific development. So just to clarify, I have no conflicts of interest other than I'm an employee of the hospital in which this data is from. So specifically, the learning objectives for my section of this talk is really to understand how a program has evolved to treat concurrent substance use, mood, and anxiety disorders as a result of a measurement-based care framework and foundation that is across all of our services. Understand how standardized measurement has supported that decision-making as it relates to concurrent and other populations, as well as consider how one might go about evolving program changes within your own facilities and settings. So just a little bit of background. Homewood is Canada's leader, or one of our leaders, in mental health, trauma, and substance use services. We've been around, we've recently celebrated our 140th years in our Guelph location. We have facilities that are in Guelph, just not far from here, if you're not around here, about 30 minutes, as well as a facility out in Victoria, BC. We offer outpatient and intensive outpatient treatment, recovery management, employee and family assistance programs, as well as various stay-at-work and return-to-work focused services. To highlight here, these are our four treatment settings, so treatment related to residential or inpatient treatment. Specifically today, I'm going to be talking about the health center that's located in Guelph, Ontario. So I'm going to pause a little bit here and just give some context to Homewood Touchpoint. That's what we have called our measurement-based care program that we've been evolving for over a decade now at Homewood. And we are at the point where Homewood Touchpoint is really an integrated online platform that is designed to facilitate measurement-based care and measurement-informed decision-making. As James mentioned, and we really do focus on that overall pillar of how measurement-based care can improve clinical practice, direct impact to the client, how do their treatments get guided, how do we celebrate the wins with them when they have the wins, and how do we overcome some of the challenges when we see those present. Specifically, I'm going to focus on that quality improvement lens. What do we do with this information in a secondary way? How can this make us better? How can we be better for the people that we're serving? And then, as James alluded to, and as Patrick will talk through, we have the research, larger scale system changes that we might be able to impact. So I do want to just put this slide, no one wants to read every point on this by any means, but really to show that this is a journey. For those of you, and we'll speak more about this later on today in the workshop, but no one starts out with a perfect system in place or a new program in place or any of those. And so for us, this has been more than a decade in the working, And sometimes you feel like you're still at step one, and sometimes you feel like you've made progress. When we can see the impact on program changes that we're having, when we can hear what the patients are saying about those changes, when we can see the effectiveness of those programs through some of the outcomes, we do see that we've made headway. We're making movements in the right direction, but I think there's a lot more movement that we can make. James also had this slide. My next two slides I stole from James without asking, so thank you. We're really that foundational piece about a learning health system or a health learning system. We're really at a spot now at Homewood specifically that I feel like we have the beginning foundational stage of a health learning system. We can understand more than we could 5 years ago or 10 years ago, the people that we are serving. We can see how they're presenting. We can understand where there's gaps in our services or larger system services. But again, that's still within our network our network or what we have control of. And what we are excited about is collaborations with James and others as we expand this network or this measurement system, that we can then maybe better understand how Canadians are doing across the way, where those gaps are. There's definitely more need than service, and so if we can expand how we can use this to help open more of those doors, that's the ideal state. So specifically here with the measurement-based care framework, I'm gonna be, I don't know if that, oh, it did work, really focused on that quality improvement lens. Again, this afternoon, we can talk through Homewood's specific journey on the patient care lens. That was the primary focus, or if you have any other questions afterwards. So I have one little slide on concurrent disorders. We have seen from the previous two talks that we know concurrent disorders is very prevalent, and in fact, it's increasing in numbers, much as mental health needs and substance use needs are in general. This was specific data to Homewood, just for us to have that idea or notion to put forth that our data is also supporting this, and that the largest proportion of our clients that we're seeing also have concurrent disorders. But what this meant for us was it was a time for us to reflect on what do our programs look like. Do our programs have capacity to treat concurrent disorders? Have we maximized that capacity, whether that's resource? Do our teams know how to treat concurrent disorders? I think James alluded to the fact that we don't always ask the questions that we might not be comfortable solving. So how do we help build up that capacity and that cultural competency around those other areas that people maybe feel less skilled at? But also within our makeup of whether it's beds or outpatient services or a clinic or what have you, do we actually have the right setup to treat the most complex people that we're seeing, which is also the largest majority of folks that we are seeing. So this led us to review all of that within our facility and what made the most sense to really treat the people who were waiting at our door, needing help and wanting care. So that led to the development. It actually launched last winter, so we're still not even in a full year of data and programming, but our integrated mood, anxiety, and addiction concurrent program. I'll challenge anyone to remember what this acronym means later. But our IMAC program was really born out of this understanding and learning that we've been developing through understanding the people that we're serving in a better way. So just to highlight, within our programs at the Guelph location, we have multiple programs that we offer in an inpatient stay. We have an addiction medicine program that is treating primarily substance use programming now. There was some concurrent treatment in there, and that's where we were able to maximize some of our learning, evidence-based practices to lead into a more fulsome programming. We have trauma programming that focuses on general adult population, as well as first responders and a women's programming. The women's programming is also something that has just been launched in this past year, again, partly developed by the need that we were seeing within our measures and understanding that there was a different way that we needed to approach that population. I won't go through each and every one of the other programs. We have eating disorders, we have assessment units, we had a mood and anxiety program. We also have an interventional psychiatry service where we offer RTMS, ketamine treatment, and ECT. So this is just to highlight what are the core components of our integrated mood, anxiety, addiction, and concurrent program. And it's meant to be able to support anyone who has a mood, anxiety, and/or substance use issue. They are 18 plus. The program length is roughly 9 weeks. There is a slightly longer program that is available. We are able to also treat older populations in a slightly different way because there's some different programming and needs that might make sense for that group. We have various modalities of treatment, including mostly group-based programming. We have holistic additional adjunct programming around horticulture, music therapy, rec therapy. We have OTs, nursing staff, psychotherapists, addiction counselors, psychiatrists, addiction doctors, all available within this program. And a foundational part of all of our programs for the last 5 years has been measurement-based care underlying all of these programs as well. So I'm just going to highlight a few of our early outcomes that have actually not, this is the first presentation of these, that really show the shift in our depression symptoms within this program. So this would be the first 8 months that the program was open. The colors do not look great on that screen, but the bars on they're slightly lighter. The purple is the scores at intake. So you can see the large proportion of individuals had moderately severe and severe depression at the time of intake. And then you can see how that shift moves where the largest proportion of individuals have mild or less depression symptoms at the time of discharge. You also see a similar trend or path in the anxiety. Again, a larger proportion of symptoms at intake, and those are decreased by discharge. We also have the ability within our system to now follow people after they leave. So again, we're only at 8 months into the program, so we don't have a large cohort of people that have left. In some of the other programs in which we are seeing that, we are able to see that they are able to maintain most of their program gains after they leave. So we are seeing somewhere around 50 to 60% reliable change indexes, which is really just a statistical term to say clinically meaningful change, improved functioning, reduced symptomology at the time of discharge. And those numbers are holding to still about 50% in those follow-up phases up to a year. We also have measures of cravings that you can again see a similar pattern, very high, moderate, and severe cravings at the time of intake, and those drastically drop off at the time of discharge, as well as our therapeutic alliance. So that's a key measure that we capture as well in all of our programs. If it's an individual care program, it would be related to your individual therapist. If it's in a group-based programming, inpatient stay, it's related to their overall treatment team. And you don't see as much of a large shift in here because the therapeutic score was actually over 90% at the intake score as well. They're doing that measure within the first 3 to 5 days of their stay. But you do see by the time of discharge, specifically the very first bar on the left, that the scores are at the highest rate of very good, had increased more so. I think this is just really important also for our teams and staff to see. And we want to have this as a core measure as we know that it is still the largest predictor of outcome. And so we want to make sure that we have an understanding and we can address this if there's issues related to your therapeutic alliance or bond with your clients. I also have some early satisfaction metrics to share. I won't read every one of these comments, but just to highlight, early signal is coming in on whether patients would recommend the program, whether this new program is meeting their needs, and if they felt the staff were helpful in their recovery. So this is really promising and exciting for our teams to also see that there's benefits in here. What we have just started to go through is pulling out a qualitative analysis of all of the comments so that we can also bring back those learnings that we would gather from that feedback. Specifically though, I'll just highlight 2 of the ones that I've put on here that are really talking about a more positive experience. So thank you for helping me be my best self. Homewood provided me with an immense experience and the ability to break the cycle I was unable to when I was at home. I am grateful for the family or for the quality of care I've received from an experienced and knowledgeable interdisciplinary team. I'm leaving Homewood with the confidence to return home and continue to practice the skills I've gained during my 63-day stay at the IMAC treatment program. So I think this is why we're all here. We want to know that what we're doing is having an impact. But what is exciting for us is that we were able to take the learnings and understandings that we were gathering through our measurement-based care system, as well as feedback from satisfaction surveys, directly from clients, directly from referral sources, directly from our staff experience. There's many sources of data to really help us identify that this was a gap in our service. It was our largest wait list. It continues to be our largest wait list because the need is around this current complexity that we're seeing. So to summary, we know that there's a high need for concurrent treatment. So far in the early stages, we're seeing an overall positive outcomes and some signal that the program is effective. We'll continue to look at this. This is another part of that CQI, the ability to have evaluation and respond to it. Our satisfaction is high. What we want to continue to do is look at evaluation here. Is there other ways to identify at-risk clients? We have a poster that's over there that we're looking at our measurement-based care system to understand in that intake, do we know when clients come in and they might be at greater risk of leaving early? And then of course we know the adverse side effects if somebody doesn't finish the care when they've started. And so we want to help those clients identify who they are and help them stay in treatment so they can actually get the gains out of the services that we're all providing. As well as share these learnings and understanding into other programming. So like I mentioned at the beginning, this is one example of how we've used this system to directly change our services. We've also had learnings about changing the threshold scores on like a GAD or a PHQ and what that looks like in our setting to understand, and we've been able to adjust our care so that we're using the thresholds that we've published within our own populations. So what we're really trying to do is work with the research team and otherwise to take our learnings and in real time put them into programming and results and services for our teams so that we can be responding to everything that we're learning. So it's this really functional learning, changing, ongoing system. Overall, for measurement-based care, there's benefits at the client level. There's benefits at the clinician level to understand their clients. It can help bring things to your radar. It can also just help provide maybe spots or narratives that you can start to connect with your clients. If there's a stuck point and you don't know, it might help you gain that, or you might be able to say, you said this to me, or I witnessed this, but I also saw you answered this questionnaire like that. Let's talk about that. And then it really allows us to have a better understanding of who we're serving, how it's going, where our gaps are, and how we can do better for the individuals we're serving along the way. I think it's just important, my best advice for anyone on this journey is just to start. It's not going to be perfect the first time you do it, but you can continuously evolve it, and that's what we've been doing for the last decade or so. And ultimately, to end on James's note, is we are really hoping that this can lend itself into a larger health learning system, so the overall Canadian healthcare system related to substance use can really improve and benefit from these gains.
Thank you very, very much, Shannon. So anyway, lots to chew on there, and we'll have some time the last half hour at the end for us to have some discussion and engage. So keep your questions in mind so you can bring them forward when we get to that section. That was amazing, Shannon. So our last presenter is Patrick Duns, and Patrick is a Research and Evaluation Associate at Homewood Research Institute, where he contributes to the design, execution of research and evaluation projects. He also has a master's in kinesiology with a specialization in neurophysiology and undergrad in psychology, neuroscience, and behavior, both at Mac University. So as I mentioned to you, if you're like me, I get really excited when I hear about the new novel treatments that are, that's kind of silly to say, new and novel at the same time. Anyway, the novel treatments that are coming down the pipe that really help us be able to make some headway for those folks who may not be able to benefit, or offering the best that we can to them as with the more traditional treatments that we have in our toolbox. So what we're going to hear about from Patrick today on what are the patient and provider perspectives on the use of these approaches, and what can we learn from them as we consider incorporating them into our practices. Over to you, Patrick.
Okay.
Thank you so much, Kim. Hi, everyone. Welcome, and thank you for coming to our symposium here. I'm excited to bring this work from Homewood Research Institute, where we have investigated the perspectives and opinions of both patients and clinicians regarding the use of novel treatments for substance use and concurrent disorders. Okay, but just before we start, I'm here representing HRI, which is an independent charitable organization, and I do not have any conflicts to declare, nor any affiliations, financial or otherwise. Okay, so you've kind of heard of this from the past presentations, but just for a bit of background, many individuals with substance use or concurrent disorders do not respond to standard first-line treatments such as CBT. And as such, adjunct or alternative treatments are being researched to potentially fill this gap and are therefore becoming more important as demand increases for these more novel treatments, more important to understand. And we've seen evidence of increasing popularity in the past few years. So you can see on the slide here, there's a new ketamine-assisted therapy clinic in Waterloo, as well as a new psychedelics medical research center opening in Kingston. So we're seeing more interest in novel treatments, and particularly in the realm of psychedelics. Okay, and there are also a number of other novel treatments being investigated. So James mentioned RTMS or deep TMS. There's also neurofeedback. So many different novel treatments here. And so we're interested in these 10 different treatments that you can see on the slide here. So we included CBT, so gold standard treatment, which is most commonly used at Homewood. And so that's what we believe most patients and clinicians would be most familiar with and understand the most. But we also include other sorts of treatments like deep brain stimulation in this study, which we expected very few patients and clinicians would actually be familiar with. So we have this kind of range of different treatments that we wanted to investigate. As you can see from the top of the slide, some of these treatments have regulatory approval for mental health indications, whereas some do not. So we wanted to investigate that kind of range. We also have the slide here saying that there are some treatments with more evidence for them, for their use specifically with substance use disorders or other mental health indications, as well as some with less evidence for that. So we wanted to really investigate this kind of range of treatments to see if opinions differed regarding these treatments with more or less evidence for their use, or if opinions differed regarding those with or without regulatory approval for mental health indications. Okay, and so due to the novelty of these alternative treatments, little is actually known about the real-world patient and clinician perspectives and opinions regarding these treatments. And this is an important point because research on novel treatments may be able to indicate effectiveness or lack thereof. However, if real-world patients or clinicians are not willing to accept or recommend these treatments, then researchers may need to consider other treatments, add to the existing evidence base for these novel treatments, or try to alter the treatment to improve acceptability. And so the purpose of this study was to better understand the perspectives of patients and clinicians, and further to test the waters, so to speak, regarding acceptability of the treatments if offered, or willingness to recommend the treatments to eligible patients. And the findings for this study will be useful for informing future programming and future research opportunities as well. Okay, and for some methods, we administered 2 surveys, a patient survey and a clinician survey. Both were used to assess attitudes and opinions towards novel treatments. Patients were recruited during their morning rounds, whereas clinicians were recruited through email. We recruited 78 patients and 26 clinicians from Homewood's AMP, or Addiction Medicine program, as Shannon mentioned before. And the survey was only of individuals at Homewood, which is not necessarily representative of other contexts, of course. As well, the low clinician sample size may affect our ability to draw conclusions from this work. However, since this was more exploratory, we didn't consider this to be an extremely limiting factor of the study. We also defined clinician as any kind of healthcare professional in the addiction medicine program, so this also included staff as well. So here are some participant characteristics for you to observe. So for patients, the majority were male, with a small percentage of females, and then of course there was some missing data there. In regard to age, the majority were in their 40s, with also about 20% or so in their 30s, so more around that range. For clinicians, we kind of saw the opposite patterns in terms of sex. So for clinicians, the majority are female, with some, a smaller percentage being male. And then in terms of age, most are between the ages of around 30 to 49, and then there's also a good percentage of that in the under 30 category. And the surveys themselves contained general descriptions of the different treatments. So here is what you may observe if you were taking the survey. You would first see this picture, which would depict the treatment, hopefully, to the patient or clinician. And then you would see this kind of general description here, where it would include evidence-based dosage, how the treatment works, any side effects or risks that you may incur from taking this treatment. We also controlled the word count of the description that you see there. So then each presentation of the treatment was as similar as possible. And we also controlled the description to be at or as close as possible to a sixth grade reading level. Okay, and after this description was provided for the treatment, there were a number of forced choice questions that were provided to participants. And they differed very slightly based on if the participant was a patient or a clinician. So for patients themselves, they were asked about the level of knowledge that they had of treatments before the survey. Also the likelihood of symptom improvement from the treatment, their perspective on it, of course, and their likelihood of them accepting the treatment if it was offered to them. For clinicians, they were asked about their level of knowledge about the treatments as well, if they agreed that treatments had promise, and then, of course, the likelihood of them recommending the treatments to eligible patients. So all participants were also asked if they had any reservations regarding these treatments, and this was an open-ended question that was coded later on. And finally, participants were also asked demographic questions at the end of the survey. Okay, so these are the results of the forced choice questions from the patient survey. I understand that there's a lot to look at on this slide, and you can't really see the means there, but I'll try and walk you through it. So first, each bar on each graph depicts the mean response value from a particular treatment for that question. And the y-axis of each graph lists each of the different treatments. So you can't really see them there, but CBT is at the top for all of them, DBS or deep brain stimulation at the bottom, and then we have a range of other treatments. I won't go into all of them. And then so the x-axis actually shows the range of these mean values, which may change across different questions, of course. The error bars here are 95% confidence intervals. So although we didn't do any statistical tests on our data, due to the more exploratory nature of this study, any error bars that don't overlap may indicate that those means are different. And then on the bottom left, right about here, is the range of answers for each of these graphs. So you can see knowledge level here from 1 to 3, not at all knowledgeable to very knowledgeable, and then probably less likely that you'll see this, but likelihood of symptom improvement and of accepting the novel treatments right there. Okay, so as you can see from the knowledge level graph over here, you can't really see that pattern there, but that's okay. The means are organized from greatest to least, top to bottom. So CBT was at the top with the highest mean, which is of course what we expected, and then deep brain stimulation was at the bottom with the lowest mean. We also saw that the modes were the lowest response, so that was 1 or not at all knowledgeable, for most of these treatments, showing that patients didn't really actually know about most of these novel treatments. And an important pattern that I'd like for you to notice is that here we have these 4 psychedelic treatments at the top here. So there's psilocybin-assisted psychotherapy, IV ketamine, ketamine-assisted psychotherapy, and MDMA-assisted psychotherapy. So those are all rated quite high in terms of patients' knowledge there overall. And we see the same pattern as we move over to these other graphs on the right here. Sorry about that. I'm just looking at the slide. Yeah, so we see this same pattern here. We see that they're rated higher with the means, but we also see that the modes are higher. So especially with the likelihood of accepting novel treatments, we see that the modes are actually at the highest level, so very likely that patients would be accepting these treatments. Okay, and we also asked where participants obtain their knowledge of novel treatments. So as you may be able to notice here, a large percentage of the graph, 47%, almost half the responses, said that the survey was their only source of information about the novel treatment. And so even when we split this across treatments, the survey was the primary source of information about all of these novel treatments except for CBT. And this could be for a number of different reasons. Patients may not have received information from their doctor or therapist about these treatments because they're lacking regulatory approval, or because the clinician didn't think that it was relevant to that patient. But regardless, adding knowledge generation activities to give patients more information about these treatments, whether novel or established, would be very good for contributing to more informed decision-making on their part. And there were also higher numbers of responses for the internet, which is in red there, as well as other media. So we see that specifically for psychedelic treatments versus CBT. So specifically showing that these psychedelic treatments may be shown more to patients through the media. Another thing that I'd like you to notice about this graph is that there's still a sizable percentage of information that patients are getting from these kind of varied sources. So from the internet, other media, family or friends, or other sources, and they account for a little bit over a third of that. So this would be an important point for knowledge generation again, that we want to make sure that patients are obtaining the knowledge that they need to from programs, from their clinicians as well, for novel treatments and also for established treatments. Okay, these are the mean results for clinicians at Homewood. So the bars are organized according to how they were for the patient results. In terms of knowledge level, CBT was overwhelmingly the highest mean, whereas clinicians knew relatively less about most other treatments, as you can see by most of them being kind of below the middle value here. And so clinicians answered also based on how much they agreed that a treatment was promising, if I'll remind you, and then also the likelihood of them recommending the treatment to eligible patients. So there weren't really any other kind of clear patterns that we could pick out here like we did for the patients. However, clinicians seem to feel mostly neutral to positive about all of these novel treatments, and then of course very positive about CBT. So same as patients, we also ask clinicians about their sources of knowledge for novel treatments. And as you'll be happy to see, most of this knowledge, so a little bit over half here, was obtained from other healthcare professionals and also from their education or training. So clinicians are sharing this information, and they're also learning about these novel treatments the majority of the time. But then we also see that 18% here of the responses for sources of knowledge are specifically just from the survey for novel treatments. So that is an important point, again, for knowledge generation for clinicians as well. If that moves on, there we go. Okay, participants were also asked if they had any reservations about accepting the treatments if offered to them. So they were asked this after the presentation of each treatment. Reservations were sorted into codes for both patients and clinicians, and the most common the most commonly cited reservation for patients was harm or potential risks. And that was across all treatments. So meaning that patients seem to be more concerned regarding potential side effects or risks of these treatments. The highest number of reservations were cited for deep brain stimulation, and the least number of reservations for deep TMS and neurofeedback. That last point is kind of interesting, as these treatments were not among the highest rated for patients, as you may have seen on the previous slides, but they were instead less known, but in more of a neutral standing when it came to opinions on likelihood of symptom improvement and likelihood of accepting the treatment if offered to them. And specifically for deep brain stimulation, this is also This also kind of makes sense that participants would have the most reservations about this, as it is the only novel treatment that we included that it has surgery involved. Okay, for CBT, the most common reservations cited was in regard to patient fit, which we defined as anything relating to medical fit, personal preference, or lifestyle. Now, for clinicians, the most common reservation for them was a lack of knowledge about the treatments. So this could mean that there's a space for novel treatments in continuing education for clinicians. In this context specifically, the highest number of reservations were cited for deep brain stimulation, the least number of reservations for neurofeedback, as well the most common reservation was for CBT was patient fit, and these are all in accordance with the patient perspectives as well. And in regard to the psychedelic treatments, clinicians most often cited weak experimental or preliminary evidence for these treatments. So they didn't feel as good about these sorts of treatments, these more psychedelic treatments, as the patients seemed to. Okay, now to conclude, patients report higher knowledge of and interest in psychedelic treatments or psychedelic-related treatments as well, like IV ketamine, psilocybin, and ketamine-assisted psychotherapies. They report less knowledge of and interest in several approved treatments, like the different versions of TMS, so rTMS or deep TMS. Patients are also not very enthusiastic about ECT, which, although it has regulatory approval and it's actually currently offered at Homewood, it was rated second lowest in terms of how likely it was to improve their symptoms and how likely they were to accept it if offered to them. We also see a correspondence between the responses between likelihood of improvement and likelihood of acceptance. And for clinicians, they're very knowledgeable of and recommend CBT to patients for the most part. They also report lower knowledge of and more caution about novel treatments, which we attributed to an appropriate hesitation towards these treatments given the existing evidence base. However, for most of the treatments, there is a neutral to positive outlook. So some clinicians agree that most of these more novel treatments may hold some promise for the treatment of concurrent disorders or substance use disorders. Okay, and if I can remind you, patients are interested in treatments involving psychedelics. I think that point has been made clear. When compared to more stimulation-based treatments, as we saw, there are many potential reasons for why this could be the case. However, some of these reasons may relate to the familiarity of these treatments, relate to the familiarity of these treatments. Psychotherapy and medication-related treatments may also be easier to understand when compared to brain stimulation treatments. And brain stimulation treatments may also be more frightening because of potential side effects. So, example, for ECT, there are negative cognitive side effects potentially. Okay. And psychedelics are also gaining popularity in the media, which we saw by those CBC News posts there. So therefore, patients may not be, or may be more inclined to not only hear about these more psychedelic treatments, but they may be more exposed or may be searching them up a little bit more as well, just to get more knowledge about them from what they've seen in the media. Sorry, if I go back a slide. There we go. Sorry about that. Patients also indicated their sources of knowledge regarding novel treatments. So for most of the treatments, the survey was the prevailing source of knowledge regarding these treatments, which may now create an opportunity for further knowledge generation in this type of context. However, the sources of knowledge were more varied when it came to psychedelic-related treatments. So many responses showed that patients were obtaining their knowledge from these treatments more just from the internet, from other media or other sources as well, so they're more varied. So ensuring that patients are getting the right information about potential treatments is paramount to ensuring that they make informed decisions and receive the best care for them. And for clinicians, their lack of knowledge about novel treatments was likely a contributing factor to their overall more neutral stance regarding these novel treatments. So they didn't know about these treatments, so they're not likely to accept them, but they're also not likely to discount them either. And this may be an important point to improve upon educational resources for clinicians, specifically in these environments, but also elsewhere, so that they can obtain information on these novel treatments more easily. And one last point that I'd like to make is that clinicians also cited weak or experimental evidence as a reservation about novel treatments more than patients. which may indicate that they're paying more attention to these aspects of treatments. And for future work, we may want to investigate psychedelic treatments and their effects more, and also improve upon knowledge generation for patients and clinicians, which may contribute to more informed decision-making and more personalized care for individuals with concurrent disorders or substance use disorders. And thank you very much for listening.
That was fantastic, Patrick. Dave, do you have the microphone to go around the room? People, oh, there's the man. Excellent. So while people prepare and think about their questions, we've got a good amount of time as promised for discussion and for sharing maybe your experiences with some of this as well. And I hope you can kind of see the theme as that ran through here, right? So we've got concurrent disorders being the norm, rather the exception. We have rising rates of concurrent mental health and substance use problems. We have data that shows that maybe the programming that we're offering traditionally isn't only capturing and being able to meet those needs based on what people are presenting with versus what we're actually able to offer, and using our ongoing evaluation not just to only guide clinical care but change programming. We've seen as programming changes that we're able to have better outcomes and responses for our patients in many of the types of services that we offer, and then using that CQI lens to be able to continue to evaluate as the needs and frankly wants and preferences of our patients continue to evolve. And then of course we saw with Patrick that even if we may have the most helpful or beneficial interventions or ones that are underway and need to be studied, interventions are only as good as clinicians and patients' acceptability and preference for them. So how do we, better engage both, and I don't want to just say patients because many of the people that need to be served actually don't have the opportunity to be patients. So people, many who are struggling, who can't get access to care, to know what are the appropriate interventions that are for out there, understand how they best need to receive those interventions, and us as clinicians on how we're going to make sure people get the care they need in the ways that matter to them. So with that, I did see Dave. Oh my goodness, Claudette, right? Sorry, it's really bright. Please, go away, go on.
Okay, I hope I'm not ruining the process, but I did submit my question.
Well, I don't even know where the papers are. Are they here? I'm not sure. Go ahead.
Yeah. My question was about Homewood. I really appreciate learning that we can identify a subgroup of people who need the extra work, because we all know resources are short, and that makes sense to me that we would find that group of people. I work mainly with people living in remote First Nations, and the intergenerational trauma is so deep, and we heard a little bit about it in the opening remarks for the elder, and I'm grateful for that. So my question is, would Homewood consider a subsidized, separate, but equally holistic stream for Indigenous patients who've suffered intergenerational trauma and live with addictions? Because I find it very challenging to find that kind of holistic care for the deep healing that's needed. And these are people who often a 3-week program doesn't even scratch the surface. So, but I've never had any luck getting one of my patients into Homewood. So a new project for you.
Thank you, Claudette. And I think that access to, needed complex care is so important. Shannon, do you want to take that? And we'll make sure the mic works as you go.
Can you, yeah, it's working?
Beautiful.
So I'm just going to touch on an answer to that, but we do have a booth on the other side, and Deanna Brady or Paul Obermeyer or Candace could definitely give you more information on connecting, figuring out a pathway in. We do have specific programming at our Ravensview location out in Victoria, and we have some of those learnings and stuff starting in our Guelph location as well. So we have specific programming for those populations already out in BC, and we have some of that started here in Guelph. But I think that your point is very accurate. It's another population that has different needs that needs to be addressed and serviced to meet their needs specifically. And we have tried to do that, and we do have mechanisms in which to do that, but I do recommend that you connect with Deanna at our booth, which is just on the other side of that wall afterwards for more information on how to make those connections and who to talk to and get that intake process kind of figured out for you. Yeah.
Thank you. I think we have a question from everyone in the room, so which is fabulous. So what I'm going to do is, you may not hear your question asked directly the way it is, but it's not because we haven't read them. I'm just going to try to integrate multiple questions together so we figure out how we can get everybody's 40 questions here responded to. But I'm so excited that people are interested. If you don't get your question answered, we're going to be around for a few minutes afterwards, so you can always come on up and do that. So I think we have a few questions here in terms of James, in terms of your talk on who was more likely to leave without a mutually agreeable discharge, what we know as AMA, but I'm trying to come up with a nicer word.
Sure. So that study found that the subgroup that had alcohol use disorder and limited other comorbidities had a significantly higher probability of completing the program. And the subgroup that had illicit drug use disorder and elevated depression, anxiety, and PTSD was significantly less likely to complete the program. So we saw meaningful differences in prognosis. Now, the rates overall are not all that high, which makes it a hard thing to predict. Only about 10 to 15% of individuals will not have a completion, so it's a pretty small group, but it does seem, and it confirms clinical intuition, that the more psychiatric complexity, the higher probability that the person won't necessarily complete the program and really get the intended dose of treatment, which is the very beginning of hopefully promoting a successful recovery attempt.
Thanks so much. So we got a few questions about measurement-based care, which I'm going to kind of lump together in a few. So, and the first is our understanding about why we're saying concurrent disorders is on the rise more national data, or is this really coming as a result of measurement-based care? And I think the piece there is if you seek it out, is that why we see it, or is this something that we're seeing more broadly? And I think the other pieces along these lines are, so you got this system, but how, what are the processes or some advice on the processes of implementing this system for measurement-based care as part of our tool, and do clinicians actually use it into patients' care? Again, summarizing, nobody wrote it like that.
So I'm happy to speak to the first part of that question, which is really why we are now so much more aware of it. And I think it's a bit of both. So the first issue is, if you don't ask the question, you can't get the right answer. So a lot of our large-scale epidemiological surveys now are doing a better job of assessing both substance use and psychiatric conditions. And unfortunately, there is a long history of there being substance-specific epidemiological surveys and mental health surveys, and we have in our language the convention of mental health and addiction. When addiction is a mental health, a psychiatric condition, we somehow parse them as being different. When you address them all concurrently, no pun intended in this case, you then get the actual rates of overlap, and that's happening. So I think we're now much more aware of it. I also think that within clinical settings, there is a much greater appreciation of concurrency and transdiagnostic assessment. And so like at the 10,000 foot perspective, at the 10 foot perspective, clinicians are just much more attuned to ask questions that they may not have before. And programs are increasingly discontinuing the practices of, for example, saying, we'll treat you, but not until you've stopped drinking. Or we can manage your drinking, but your suicidality or your depressive disorder is too severe. And we have historically had that kind of tracking problem that simply means that patients who have concurrent disorders don't get care. So I think it's happening at a high level and at a lower level.
Yeah, and if I could just add to that, I think we talk a lot about concurrent disorders in our clinical samples, but if we look from a national or general population point of view, we actually don't have really good national prevalence data. And I think the last study actually was from the early 2000s, so a lot of our national data relies actually on US data or from some other countries. And I think if we look at some data that came out from Mental Health Commission of Canada and Canadian Centre on Substance Use and Addiction that was during COVID, what they found were increased rates of substance use amongst the general population, increased rates of mental health concerns amongst the general population. And then if they looked at that group of people who reported both mental health, who had mental health concerns, that group reported higher rates of substance use concerns than those people who didn't have a mental health problem, and the corollary of those people with substance use health problems had reported higher rates of mental health concerns than those who didn't have them. So that's some of the indications we have from general population as well. So over to implementation, and as you answer that, and questions just came in, so think about processes, given the role of families in our wellness journeys, how is family accommodated for and the perspectives of family involvement in the measurement-based care as well?
So I think that the first part of the question about measurement-based care, if you're interested, at 3:30, we have the work, 3:45.
But if they can't come.
But if you can't come, yes. But we do have a workshop where we'll go in more detail. We also have a means in which we have some tool kits and processes and whatnot that are almost ready to be released that can also help facilitate, or you could reach out to myself or anyone on this panel and we would make those connections for you after. But the short version from me is that I think you don't have to think I need to have this massive system that does all of these things right when I start. If you could pick one or two measures, likely even like literally the GAD and the PHQ, depression and anxiety, they will move, those measures will move kind of transdiagnostically as well, to track progress monitoring over time. If you don't have means or resources to have a technical system in the background, they're short, they're simple to calculate, they're a piece of paper, you could do them, the client could do them in literally under 5 minutes, both, and it would give you a starting point for those conversations. And then, this is what we did at Homewood, we proved the concept. This is worth investing in, the research is showing this, we did have some top-down interest in it, but we literally did a feasibility to just figure out if we do this in a small scale, in paper-based, is it worth it? What did we get? Bring that feedback back to the client perspective, the clinicians, the senior leaders, researchers, everybody on that iterative journey. And now we have, I don't know, we're probably on the 5th or 6th technology platform in the background, trying to manage the data. There's lots of processes once you get to that point. We also asked our clients in those early stages, what was important to you? What is the outcomes that matter to you? We had that from our clinicians. We had that from an overall system point of view and research. And then at the tie-in to the family is we have family-specific programming tied to most of our programs as well. So we tend to get feedback and information that we incorporate into that care process through those family engagement practices that we have already had established within our programming.
And I wonder if we'd be able to share, I don't think that's specifically in the implementation toolkit, but I think if there's specific questions perhaps about what that engagement looks like for families, happy to be able to share some of that information too. Thank you.
Yeah, chime in about adoption? So first of all, I would agree with Shannon's point 100% that fundamentally don't let the perfect be the enemy of the good. Get started, see what works, what doesn't work, and iterate from there. But from an adoption standpoint, the big issue often is not assuming that if you build it, they will come. Simply having a system doesn't mean that clinicians will use it and that it will be considered beneficial. It may ultimately be considered onerous and low in terms of tolerability. So you have to assume that clinicians will use tools that help them treat their patients and maximize care. And it's really critical to create channels for feedback about what's working and what's not working, and create clinical protocols and pathways for using the information in a way that really optimizes the data for the clinician and doesn't add one more thing to an already very long to-do list when it comes to clinical care.
Yeah, and as someone who's been, doing this work at a couple hospitals and community centers community health work where I am in Ottawa, I think our biggest facilitator was actually working alongside the clients for its implementation, because once the clients started asking for, where's my tools, where's my measures, I want to see how I'm doing, it really engaged our clinicians and folks to integrate that into their approach, because it had meaning for both groups. And I think people do what they do for their wellness and for the work they do when they feel it's meaningful and making a difference. So, okay, so questions for you, Patrick. So a couple things in terms of I'm just going to put a couple of them together so you can kind of weave together your response. For the patients involved in your study, did any of them actually, I think what this means is, have a history of RTMS, ketamine, or ECT, i.e. were they receiving some of these more novel treatments? And then with that, given what we noted as a gap in terms of psilocybin and ketamine, what's really the efficacy of this intervention, and where does mindfulness fit into all this?
Okay, so for the first part of the question, yes, I believe I did see some reservations regarding that. So when we asked patients about their reservations, some may not have fully understood the question and they just kind of answered what they thought. And so some did answer, yes, I received ECT, or someone that I know received ECT, and so they kind of went anecdotally from that. So we do know that there are some patients who did receive RTMS or ECT, not necessarily in this study, but we do know that as well with our interventional psychiatry service, we do offer those treatments. We offer RTMS and ECT in that sense. So we do know that. In terms of the second point of the question, mindfulness?
Mindfulness and then the efficacy of, because we're talking about, maybe clinicians not having awareness or feeling there's low efficacy for psilocybin or ketamine. So what are the long-term efficacy of those? Do we know? Does anyone want to comment on those? And then the second piece was just in terms of where does mindfulness fit in terms of, we talked about CBT, you talked about other novel, is mindfulness, was it reviewed, or how do you see that fitting in?
James, would you know about efficacy regarding that?
So one of the issues we faced in designing the assessments was that we expected that there would be a lot of variability in what people knew about the intervention. So we included in the structured description of the interventions what was known about efficacy, because as Patrick illustrated with our evidence spectrum, these interventions ranged from what we would consider sort of gold standard, best studied, standard of care, to completely experimental science fiction, extremely unknown in terms of outcomes. And so we provided that information to both the clinicians and the patients in order to give everyone kind of a level playing field for their attributions. We did this pretty concisely based on our review of the literature and the extent to which there were trials or existing meta-analyses. But of course, there is a lot of variability, and I think that especially in the clinician responses, we saw that there were concerns that correctly, the jury is out on whether some of these interventions work or not. Some are Health Canada approved, some are what we would consider our first line, others are at the vanguard of the field, and that's what we were trying to learn about. So we tried to make sure that there was a kind of consistent information baseline for everyone, and that we gave a fair perspective on what was experimental, what was established. In terms of mindfulness, we didn't explicitly incorporate mindfulness per se. When I think of mindfulness, especially in this context, I would think of mindfulness-based relapse prevention, which is part of the kind of canonical CBT techniques that are used nowadays. But that was not part of our, one of the treatments that we evaluated. We used CBT largely as a sort of reference point because we assumed that both patients and clinicians would be most familiar and would have the least reservations. So it represented a kind of benchmark against which we thought we would be able to evaluate the extent of differences. But we didn't really differentiate within CBT.
Thanks. And Patrick, do you have anything else to add, or we're good with that one? Good. So I think the question that follows up on that is, okay, so we have these treatments, we know some that are helpful, but even some of the ones that are kind of standard of care aren't actually free or accessible, or ways people can actually get it. So how will this work be able to maybe help facilitate access to care, including cost coverage? And then the second piece is, how do we actually get information out there to the people who need it to make informed care decisions?
I'm happy to speak to that. I think that now we're sort of at the interface of data and evidence and advocacy, because the reality is in our treatments that we asked about, there were a reasonable number that are Health Canada approved but are not, for example, OHIP approved. So when there are treatments that work, how does the system advocate for better access for patients to avail themselves of those treatments. And the reality is some of those interventions are available at places like Homewood, which does have some public beds, but not all of them are. And for most people, access to these approved treatments is simply not available. So I don't think that our study can directly speak to it so much as I think that as a field, we need to advocate for better access to treatments that work. And in doing so, give our patients better access to them also.
Yeah, and I think that's the key point. If you look at advocacy, right? Yeah, clinicians advocate, but our communities and the people who need the care, they need, you know, how do they help advocate? How do they ask? How do they hold us as a system and leaders accountable for the kinds of care that they need and deserve? I think we have time for one more question. Otherwise, we may be holding you out from lunch. So, question about the program, Shannon. So, two things. One, your data showed some impressive improvements, they said, in mood and anxiety for the severe group, but then it showed also an increase in all three in mild and moderate groups. Are they missing something? Like, can you clarify that?
Yeah, so think of it as that. I'm just going to use the example of a GAD. We don't have to show it, but it was. Look at this. Oh, look at this.
Yeah. I know, he's pretty awesome.
For the GAD, there's 4 severity levels. So there's none, mild, moderate, severe.
Purple
Severe
deck.
and moderate, if you score in that range, that's kind of hitting where the clinical cutoff is, that this screening tool is likely predicting an anxiety disorder. Obviously, that needs to be confirmed through a clinical diagnostic interview and all of those pieces. So what we want to see is that we've moved people out of those highest range severity into the lower severity categories. It means you've moved them out of that diagnostic threshold or criteria where their functioning is probably not really impacted. It would be early stages. And then that's where you can do more of that preventative maintenance and those self-care practices and things that we can practice and do at home to take care of ourselves. So really what we would expect to see is it's still the same population of people. We're just shifting them down to the milder end of the severity spectrum.
All right, thanks.
Just to add
Go
something,
ahead. Yes.
I had the same reaction as the question asker because it looked like the bars were before and after, but actually all of them add up to 100% and they're migrating over time to the lower severity group.
All right, and last question, and then we're off for the day. So as folks in the audience are looking to maybe do some case finding or look at developing their own outpatient concurrent disorders program, any advice to approach on this in what they're calling a concurrent disorder care desert? For people we've told people to just go, so now what?
Well, I think that the two pieces of advice I would have are to, again, to start with what is the art of the possible when it comes to doing a careful and systematic assessment of what the comorbidities are that are going to be addressed in this outpatient setting. And then also thinking about what are the elements that are best brought to bear. And I think that the Homewood IMAC program is a whole menu of options, and that may not seem like a credible one for a small-scale outpatient practice, but a lot of the elements are viable. So motivational enhancement therapy, cognitive behavioral therapy, first-line pharmacotherapy on the substance use side, but also, for example, the Barlow transdiagnostic approach to internalizing disorders and a lot of the transdiagnostic techniques for depression, anxiety, and PTSD would also naturally fall into a curriculum that would be similar to a more formal program like the IMAC program. So I don't think that every element might be available, but certainly large chunks would exist. And it's easy, it wouldn't be easy to execute, but it's easy to envision what a curriculum of concurrent informed interventions might look like.
And we run out of time, but we've done some of this work in outpatient services that, I've been closely involved in Ottawa, so I'm happy for folks to come up afterwards and ask some more questions. But we are done for the day. I think we've gotten through almost everyone's questions. Thanks for hanging out with us and for your engaging questions discussion. A huge thanks to our panelists and everybody who set this up to make this go seamlessly. So thank you very much.